So I'm Professor Brian Saunders, and this is my research colleague, Dr. Ahmad, and we're from the St Mark's Hospital in London. And we're very pleased to introduce to you our latest paper, which will be published in Gastrointestinal Endoscopy, entitled Implementation of Optical Diagnosis with a Resect and Discard Strategy in Clinical Practice, the DISCARD-3 study. Now, this is a study which looks at implementing a discard strategy using optical diagnosis in clinical practice, and specifically in bowel cancer screening. I think it's important to understand in the United Kingdom we have a slightly different form for bowel cancer screening, that patients between the ages of 50 and 74 have biannual FIT testing at a quantitative level of 120, and if positive then go on to have a screening colonoscopy. So our study was to look at the optical diagnosis concept in that very specific screening population where we know the patients are polyp enriched and where the biggest impact from optical diagnosis and discard will occur. So Ahmir, what specifically were our outcome measures, and what were we looking at particularly?
So the key outcome measure was feasibility and acceptance of optical diagnosis. And what we were also looking at is evaluating a quality assurance process that could be used in optical diagnosis. Also, we were interested in the surveillance interval concordance using an optical diagnosis approach to see if the PIVI thresholds could be achieved. And we also looked more deeply at the causes of optical diagnosis error. And finally, we've been looking at the economic and environmental implications of a resect and discard strategy.
I think it's important to emphasise that the colonoscopists in this study were very experienced and all skilled in optical diagnosis, but leading up to the study there were some criteria prior to starting.
Yes, so all endoscopists that participated undertook a validated optical diagnosis training module prior to being supervised during the optical diagnosis phase of the study.
So talk us through the methodology, how things developed.
So the study involved 8 bowel cancer screening colonoscopists who performed optical diagnosis in polyps up to 10 millimetres in size, and we were looking at the first 120 high confidence diagnoses that were performed. All endoscopists that participated took a white light and a narrowband image photo of each polyp, and then gave an optical diagnosis and a confidence level assigned with that. And for the purpose of the study, histology was used as the reference standard, and we also then, as part of the quality assurance process, carried out a number of different steps to try to assure the process.
So just to summarise, Ahmir, what were the main findings from the study?
So the key findings from the study, in terms of the learning curve for optical diagnosis, 75% of the 1,560 polyp diagnoses were made with high confidence, and the proportion of high confidence diagnoses actually reduced during the course of the study with training and feedback. In terms of the learning curve itself, for the 8 endoscopists, we found that the starting accuracy level was around 70 to 100%. And the vast majority were able to consistently perform optical diagnosis with an accuracy of 75% or greater during the first 120 diagnoses. However, there were a couple of endoscopists that showed a reduction in performance, and that really highlights the importance of the quality assurance process that was evaluated as well during the course of the study. In terms of accuracy, for diminutive polyps, accuracy was around 88%. And for 6 to 9 millimetre polyps it was 92%. And most importantly, the surveillance interval concordance between the optical diagnosis derived surveillance interval and the histology derived surveillance interval exceeded the 90% threshold when using a diminutive polyp optical diagnosis approach for both for the British, European and American guidelines. When looking at the less than 10 millimetre optical diagnosis approach, for the British and European guidelines, the 90% threshold was exceeded, but not with the US guidelines.
Even though it was easier to make an optical diagnosis, because that polyp group had a higher percentage of high-grade dysplasia in them, the surveillance intervals were slightly less accurate when taking American guidelines, but still would have fulfilled the criteria for European or British guidelines.
Yes, so the American guidelines have a greater reliance on histology, and so in the 6 to 9 millimeter polyp group we found that there was a greater occurrence of adenomas with villus components, which are no longer considered in the British and European guidelines. But the important thing is that adenomas with high-grade dysplasia and serrated polyps with dysplasia were a rare occurrence, and there were no polyp cancers throughout.
So a key part of this study was to look at quality assurance and how that can be embedded within the protocol of resect and discard. So Ahmir, tell us how we went about quality assuring the process over the course of the study.
Yes, so the quality assurance process had 4 key aspects to it. The first of it was training. So all endoscopists completed a validated optical diagnosis training module prior to starting the study. And during the course of the study, there was group training at 1 and 6 months. The second aspect was looking at performance monitoring of the last 20 optical diagnoses made during the course of the study, and all endoscopists were provided with performance reports every 3 to 4 months. The third aspect was looking at the histopathology optical diagnosis discrepancies, and we provided a root cause analysis report of all cases of discrepancy to endoscopists for educational reasons. And the final aspect was one-to-one intervention where there was any drop in performance below 75%, and so that was to try to optimize accuracy of optical diagnosis.
So just quickly, if there was a discrepancy between the optical diagnosis and the histopathology, what happened?
If there was a discrepancy, the first step was for the histopathology specimen slides to be re-reviewed, and then there were a number of subsequent deeper levels of the specimen performed, with initially 6 levels, then 9 levels, and finally 12 levels, in order to identify the cause of the optical diagnosis error. And if there was still a discrepancy after 12 levels were assessed, a photo documentation review was performed by an expert endoscopist to try to understand exactly what had led to the error.
So just to give a rough breakdown of those discrepancies, how many were due to the histopathology being initially inaccurate, corrected with deeper levels?
So in terms of the discrepancies, around 16% of the high confidence diagnoses were there was a discrepancy with the histopathology, and of those, around a third of those, there was an issue with the histopathology, of which a vast majority of those was corrected when deeper levels were analysed.
We also assessed what our patients thought of this process.
Yes, so we invited all patients to participate in a patient experience questionnaire after their procedure, and also undertook a patient focus group. The key finding from the questionnaire was that 89% of patients felt confident that the endoscopist could accurately optically diagnose to the extent that histopathology was not required.
So at the end of the study, do we get an idea about the potential cost saving?
Yes, so we've performed a preliminary analysis looking at the economic impact of a resect and discard strategy, and consistent with previous studies that have assessed this, we can see that there is significant cost saving of around $56,000 for the polyps that were assessed during the course of this study. So actually the cost of histopathology is less than half what it would have been with a standard approach.
Yes, and of course we would be able to streamline a number of those patients with diminutive polyps and give them a surveillance interval immediately after the procedure, rather than bringing them back for another outpatient appointment or another telephone appointment, which would also have a significant cost saving. So in summary, we've shown how optical diagnosis with a resect and discard strategy could be implemented into colonoscopic practice, particularly focusing on a polyp-enriched group in bowel cancer screening. And we hope that with the knowledge gleaned from this study, the information can be used to help adopt a resect and discard optical diagnosis strategy much more widely. And certainly we think this is feasible within the British bowel cancer screening programme.